Nursing diagnosis is going to be stated in a three-part statement. We sometimes talk about this as the PES statement. I will say this before I say anything more about PES, I want you to be clear that the problem, as stated, must be a NANDA approved nursing diagnosis. It can't be something that you're making up from your head, because these nursing diagnoses that have been put together by and categorized as the NANDA diagnoses have been well researched. They have been arrived at by experts in the field, experts in maternity nursing, for example, experts in med-surg nursing, experts in community health, etc., etc. So you can't come along as a new student and say, well, I think I have another nursing diagnosis. You have to identify the NANDA approved nursing diagnosis that best defines what you feel the problem is. So that's our problem statement, or the P component of the PES statement. Again, when you do your nursing care plans and when you work in facilities that are accredited and have bodies that evaluate the nursing care that is administered in that facility, they are going to be looking at your use of NANDA approved nursing diagnoses. And certainly your instructors, as they grade your papers, are going to be looking for NANDA approved nursing diagnoses. Next part of the statement is the etiology. And the etiology is what is the underlying cause of your patient's nursing diagnosis. So this is the part of the diagnostic statement that tells us, the reader, what the nurse feels underlying, where this problem came from. What's the underlying cause of this nursing diagnosis? I do want to say, however, that etiology sometimes can be unknown, and it is okay for you to have your NANDA approved diagnosis followed by etiology unknown. However, if there is an etiology, you should be identifying it. And the S part of our PES statement the S stands for signs and symptoms. The true term for those signs and symptoms is defining characteristics. What are the findings from your assessment data that indicate that this is a nursing diagnosis? These defining characteristics cannot be conjured up. They have to be found in your assessment data. Maybe it's that admission assessment data that you are identifying these defining characteristics. Now, as you use your nursing diagnosis handbook, you will see that Doenges et al. Identify the subjective and objective defining characteristics to look for that give evidence of your nursing diagnosis being validated. So you think this is the problem, you identify what the cause of that problem might be, and you identify the defining characteristics, which are the signs and symptoms that your patient exhibits. However, you use the resource of your Doe and G's Nurse's Pocket Guide diagnoses, prioritize interventions and rationales, or any other credible resource that you might want to use to determine whether these signs and symptoms are in fact listed as defining characteristics of the problem that you have identified. So this nursing diagnosis handbook helps you with a number of things. It will give you, it will state the problem correctly, the NANDA approved nursing diagnosis. It identifies many related factors that might be your etiology, and it is going to list defining characteristics of that problem. Be very clear that your patient does not have to exhibit all of those characteristics. However, you should anticipate that there will be multiple defining characteristics. Occasionally we have just one, but that's not typical. So an example of a PES diagnostic statement. So the diagnosis is pain related to that. This RT indicates what's coming next is our etiology related to surgical incision as evidenced by AEB. When you see AEB, you expect the next thing you're going to see in that statement are defining characteristics. So in this case, for pain, we have some subjective information and we have some objective information. The patient rating their pain 8 out of 10, that is a subjective finding. But this is further validated by an elevated blood pressure and grimacing with movement. Now, if I were to go to my nursing diagnosis handbook and look up pain as a nursing diagnosis, I certainly would find these listed, maybe not this exact terminology, but the essence of this will be listed as defining characteristics. So if you were to go to page 633 in your Doe and G's text, you'll find the diagnosis of pain. And they give a definition of that diagnosis, and so you would read that definition and see if it concurs with your feelings about pain, or any diagnosis you might have come up with. But let me just read you the related factors. Related to, again, related to means etiology. They've identified a biological injury, such as infection, ischemia, or a neoplasm, a chemical injury agent, or a physical injury agent. For example, trauma, an operative procedure, a burn, heavy lifting, or overtraining. Those are the related factors that the book mentions. So that really is exactly what we see here, where with surgical incision, that would be physical injury from an operative procedure. Now, with regard to the defining characteristics, there are many listed here under both subjective and objective, but one of the defining characteristics is self-report of pain, specifically self-report of pain characteristics using a standardized pain instrument. And objectively, we see change in physiological parameters, i.e. vital signs, and we see guarded behavior, protective behavior. That's not exactly grimacing, so let's see. Expressive behavior of pain, i.e. grimacing, facial expression of pain. So they indeed have listed defining characteristics that I have identified in my patient. So you're going to cluster your information. You're going to come up with a tentative list of nursing problems, and then you're going to use your handbook. Take that tentative list and work with it and the book to come up with the specific nursing diagnoses and further identify your related to factors, your etiology, and from your nursing assessment, you will have identified your defining characteristics, and you make sure that that matches up with what our NANDA diagnoses have identified all through your use of your Doenge's text. So after your problems have been identified, the next step is planning nursing care. So we have now completed our diagnoses. Now we're going to plan care for those diagnoses. Before we plan exactly what we want the nurse to do, we want to identify our goals, patient-centered goals and expected outcomes. What do we expect to happen? What do we want to happen with regard to our patient? Our priorities are going to be set relating to problems with unmet needs. We can use Maslow's hierarchy of needs as a useful way of setting priorities. And priorities can be classified as high, intermediate, or low. And we'll talk about that a little bit more in the next slide. So a high priority problem is one that is greatest threat to the patient's well-being. For example, something like fluid volume excess, for example, which can be a grave problem for some patients, or decreased cardiac output. I think you can, even with a limited background in nursing, you can probably figure out that decreased cardiac output is not a good thing. Great threat to our patient. A medium priority problem is one that is non-threatening to the patient's immediate well-being. Something like, for example, maybe activity intolerance would be of medium priority. A low priority problem is when we identify a diagnosis that's not specifically related to their current health problem, but we won't ignore it, but we will certainly deal with the high and medium priorities first. Maybe, for example, your patient who's come in is experiencing a myocardial infarction, And high priority is that decreased cardiac output or risk for decreased cardiac output. A low priority might be impaired oral mucous membranes that you perhaps identify as you do a head-to-toe assessment on your patient. Not critical by any means, but something that you want to be aware of. As you determine goals for the patient, we sometimes sort of goals and outcomes are sort of used in somewhat interchangeably. Goals are what we hope to have happen. Outcomes really are, in the end, what does happen. We have cognitive types of goals. Cognitive goals describe an increase in the patient's knowledge or intellectual behaviors. More simply, what the patient will learn. So we might have a patient who has a knowledge deficit, specifically perhaps with their new medications. And so we'll set a cognitive goal that he will learn to self-administer his medications prior to discharge. Psychomotor goal describes the patient's achievement of new skills, maybe self-administration of insulin, for example, would be a psychomotor skill. Use of drawing up insulin, injecting the insulin. These are you have to have an understanding of what you're doing. That's the psycho part. But the motor part is the physical skill accompanying that. And affective goals are goals where describe changes in the patient's values, beliefs, and attitudes. Maybe a goal stated, patient will employ effective coping skills. That might be an affective goal that you might identify. The purpose of goals and objectives is to provide direction for our nursing interventions. Our nursing interventions should flow from our goals. Additionally, goals help set the standards of determining the effectiveness of our interventions. So when we get to the point in ADPI where we are evaluating, we look at our goals and determine whether or not those goals were met. So that's the standard of determining effectiveness. Goals also can indicate an anticipated client behavior or response to the nursing care. And the purpose of goals also help us to see where the end point of our nursing care is. So if our goals, particularly our long-term goal, is well written, we can determine whether that problem can fall off of our nursing diagnoses list if the patient meets that long-term goal. Whenever possible, goals should be arrived at with patient involvement. The patient is going to be more motivated and more engaged in their own nursing care if they understand what the goals are for them to achieve. Remember, these goals are patient-centered. So if our patient is vested in those goals, they are going to not only be better motivated to reach those goals, but also more directed in reaching those goals. So let's see, a little bit more on long and short-term goals. Your long-term goal should address problem resolution or optimal resolution. So the long-term goal, as stated, should identify the end point where you hope for your patient to arrive. It should be realistic, but I'll talk a little bit more about that in a minute when we talk about writing goals. But short-term goals, there could be several of them. Okay, one long-term goal usually, but there might be several short-term goals. Think of short-term goals as steps towards the long-term goal. And meeting those short-term goals should move a patient towards long-term goal resolution. They're kind of like a path. If I achieve this, this, and this, the likelihood is I am going to achieve my long-term goal. The outcome of care is what is actually achieved and whether the goal is met or not met. So goals, particularly short-term goals, are guideposts to the selection of our nursing interventions, and they serve as the criteria in evaluating those interventions. Again, I've already addressed short-term and long-term, but again, think of goals as what you want to achieve with your patient and in what time frame. As you are writing goals, some of the things to consider with regard to goal writing is what is reasonable for your individual patient. And additionally, you can certainly use your creativity. That can come into play when planning your nursing interventions. Research findings should also factor in. Capabilities of our patient, choices of our patient, and the resources available to our patient should also have some determination as to how we are going to set up this plan, what goals are reasonable for them to achieve. And once those goals have been written, the nursing interventions will flow from those goals. As we write our goals, we want them to be patient-centered. So they're going to be statements that begin with the word either patient or client, depending upon the setting that you might be in, for example. So patient will learn, patient will state, patient will demonstrate, etc., etc. You also want your goal to be specific, achievable, include parameters such as time. For example, patient will correctly demonstrate finger stick blood sugar by the end of this shift. that might be a time parameter, or prior to discharge, or uh, something that identifies a time parameter. Again, there may be more than one short-term goal, and that long-term goal should speak to the resolution of the problem or optimum improvement in that problem. An acronym that's sometimes used with regard to goals is the acronym SMART. S being specific, M being measurable, A being attainable or achievable, R being realistic, and T being timing. So the parameter of timing should be included. So that's just an acronym that can be helpful as you write your goals. So you have gathered information, you've clustered that information, you've analyzed that information, you've arrived at a nursing diagnosis list, you have identified goals for those nursing diagnoses, and now you're going to think about, okay, what will I, the nurse, do to assist my patient in meeting those goals? Again, remember the goals are patient goals. The interventions are nursing interventions. So these interventions, again, are nursing behaviors, actions designed to assist the client in moving from the present level of health to that which is described in the goal and measured with the outcome criteria. The outcome criteria is the specific criteria of our long-term goal. Again, let your goals for your patient guide you in selecting those interventions. So nursing interventions, by the way, interventions are sometimes sort of used in the same breath or in place of implementation. So we call that the implementation phase is the nursing intervention phase as well. So don't be confused if somebody uses those terms interchangeably. So this is going to describe a category of nursing behaviors in which the actions necessary for achieving the goals and outcomes are initiated and completed. They are actions taken by the nurse. So this is the phase of nursing process that describes the nursing care to be provided. To put it very simply, what are you, the nurse, going to do? What do I, the nurse, and other nursing staff need to do to assist the patient in meeting the goals that we have identified? So we might be monitoring, we might be teaching, we might be providing physical care, we might be carrying out procedures such as a dressing change. Continued assessment is going to be a nursing intervention. So assessment, you see, it never finishes up. It always continues. So don't think of this as a linear process, because we sort of go in and out of different spots of nursing process. Types of nursing interventions, we can think of, we can sort of group types of interventions. One being nurse initiated, sometimes referred to as independent nursing interventions, what the nurse can do within the scope of practice as defined by licensure. So we can, for example, monitor vital signs without anyone telling us to do that. We can teach our patient. We can provide physical care. Nurse initiated, what we can do within our scope of practice. Physician initiated are we sometimes think of as orders. So maybe the physician has ordered specific medications, but the nurse is administering them. So it is a nursing intervention, but it is physician-initiated intervention. Treatments, specific dressing changes, for example, might be physician-ordered. Many, many possibilities there. Collaborative interventions are interventions that we utilize working with other disciplines. Maybe it's the physical therapist, maybe it's the dietitian, maybe it's the counselor or psychiatrist, or we certainly work with other disciplines collaboratively and oftentimes work under those disciplines or collegially with those other disciplines. Some other types of nursing interventions, we have standing orders. Standing orders document containing orders for the use of routine therapies, monitoring guidelines, and or diagnostic procedures for specific conditions. So we have orders that we work with that the physician, for example, might order maybe heparin for our patient, and they will identify start the patient on heparin according to the protocol, the standing orders, excuse me. Protocols, we have plans that specify procedures to be followed during the care of a patient with a specific clinical condition or situation. So, for example, if I have a patient who develops chest pain in the middle of the night, I don't have to immediately call the physician. I have a protocol that I will follow to gather more information and to alleviate or reduce the chest pain if it is related to the patient's cardiac status, but also getting more information to give to the physician before we make a call. And very often we don't need to make a call because that additional information provides us with a means of knowing that it is not of a serious nature. Our selection of our intervention is going to use our clinical decision-making skills, and the nurse is going to deliberate 6 factors. The particular diagnosis, the expected outcomes, information from our research base, feasibility, acceptability to our patient, and the competency of the nurse. So, for example, if you are a brand new nurse, you might not choose an intervention that requires you to do a procedure that you've never done before. You probably would get assistance for that particular intervention. Again, the intervention has to be feasible. We can't do everything in every clinical facility. what we can do in the hospital and do in the home environment, for example, are are quite different. And acceptability to our patient plays a role as well. As we choose our nursing interventions, use your nursing process diagnosis handbooks. Um, they are going to be invaluable to you. But when you use these books, you will see that they will list many possible nursing interventions. It's your job as a student now and as a nurse later to choose the appropriate intervention based on the consideration of those 6 factors that we just talked about. Was it 6? Maybe it was more. No, it was 6. Um, so lots of interventions listed. You're not going to necessarily use all of them. They're quite inclusive. And so for you to individualize this plan of care for your patient, you're going to hand pick the appropriate interventions for that particular nursing diagnosis. Care plans should include all aspects of ADPI. So we're going to have written guidelines for patient care, well organized so the nurse can quickly identify nursing actions to be delivered. The care plan is going to coordinate resources for care, enhance the continuity of care, and it's a means of organizing information for change of shift report. So there are multiple facilities who nurses present their change of shift report by nursing diagnoses. And so the highest priority of the diagnoses are listed first, and then we go through the rest of them, um, and use that as an organizational format. So care plans have multiple functions. They serve as our guidelines. They help us keep us organized. They coordinate our resources and allow for continuity of care, and even provide a format for documentation and shift report. Definitely documentation as well. Comprehensive planning is initially we have the planning that's done at admission, ongoing, where changes occur as care continues and new assessment findings are identified, and as some problems are resolved and other problems um, may be identified later or maybe occur later. And discharge planning um, is an important part of our planning for nursing care, and particularly so when other agencies are going to be utilized for ongoing care. So if your patient, for example, is going to a rehab facility or another acute care facility or the VNA, that discharge planning then is very important. So we can communicate information to those other facilities. So this is a very typical format for a written care plan. We have our nursing diagnosis at the top, the subjective and the objective data that substantiate that diagnosis. Again, these are defining characteristics. Our short-term goal or goals and our long-term goal, our interventions, and the rationale. Rationales certainly now while you are students and for the purposes of graded care plans, the interventions that you choose should have a rationale that you reference the resource for that information. Because you're not doing this intervention off the top of your head or by the seat of your pants. You're doing this intervention because the nursing literature identifies that those are appropriate interventions for that particular nursing diagnosis. And lastly, evaluation to determine if what our outcomes are. Implementation, this phase of process always includes reassessing our patient, reviewing and revising the existing care plan, and ongoing organization of resources, which include equipment and personnel, and ongoing evaluation of the delivery of nursing care. Because nursing care is an ongoing process, editing and changing and revising are done on an ongoing basis. So just in final look at evaluation, it's a step of the nursing process that measures the patient's response to nursing actions and the progress towards goal achievement. This information is collected on an ongoing basis. It supports the basis of the usefulness and effectiveness of our nursing practice. This measurement is going to help us to determine the quality of care that has been provided, and our various groups that evaluate nursing care use the nurse's own evaluation as measures to determine whether quality of care has been provided. Were the goals met? As goals are evaluated, make adjustments or revisions to our plan of care. If the goal was met, that part of the care plan is discontinued. We sometimes refer to it as the problem dropping off the list. And that allows us to redefine priorities, because as some things drop off the list, other things sort of bubble up as being the next most important. Or as we continue to assess, new problems may develop that automatically go to the top. So in review, nursing process, it's 5 steps. It's a circular, ongoing. It continues until the client's health is improved, restored, or maintained. It involves continuous assessment and changes in our patient's condition.